Merci, thank you دكتور صبري ويعني good morning. وطبعا I would like to thank يعني the Damanhour unit of nephrology, my very old friends, and it's always a pleasure to be here, and يعني زي حاجة كده we look forward to every year. طب I modified شوية التوبيك أو التايتل. We'll still talk about monoclonal gammopathies, but basically what I was asked to say is an update. يعني الابديت مش هيبقى قوي an update, بس يعني will be more focused on what is the scope that we consider now within monoclonal gammopathies. And you know that monoclonal gammopathies are considered a heterogeneous group of disorders. So this is a group of diseases which is characterized by clonal proliferation of B lymphocytes or plasma cells. So it's not only related to plasma cells. Any clonal proliferation of B lymphocytes will give us a monoclonal gammopathy. And the whole idea is that you produce an abnormal protein, a monoclonal immunoglobulin, which is what we call M protein. And this production of this M protein is associated with a wide spectrum of either malignant or benign conditions. So it's not always a malignant disease, but you get the lymphoproliferation. In these patients with monoclonal gammopathies, these symptoms may develop not just due to the malignant transformation, but mainly due to the idiosyncratic properties of this secreted monoclonal immunoglobulins. And we always ask ourselves, what is the cause of this wide range of clinical and pathological heterogeneity which we see in these patients? Is it that we do have an individual response to these light chains, so we have an abnormal host response, or it's related to the properties of these abnormal light chains rather than the host response? It's actually related to the properties, to the physiochemical properties of this abnormal light chains which are produced. So it is the light chains which decides whether they are going to be tubulopathic or glomerulopathic, or they are going to produce amyloidosis. It's the light chains which decide whether they are going to involve a single compartment of the kidney or more than one compartment, and hence you can get more than one presentation in the same patient as a result of this monoclonal gammopathy. When we come to discuss what we consider renal involvement in monoclonal gammopathies, we have the familiar and common entities which we all know of, which is amyloidosis, MIDD, or light chain deposition disease, or light chain caused nephropathy, what we consider the prototype, or what we call myeloma kidney. However, during the last 10 years, we have relatively new and less common entities which were included under the term monoclonal gammopathy. We have a proximal tubulopathy with or without Fanconi syndrome, proliferative glomerulonephritis, non-amyloid organized deposits GN, membranous GN, thrombotic microangiopathy, C3 glomerulonephritis, and interstitial nephritis. So as you see, احنا تقريبا we included all the renal pathology, yes, and all what we see in nephrology under monoclonal gammopathies. And hence our concern, or what we are concerned about, is what we call MGRS, which is monoclonal gammopathies of renal significance. This term have initiated around 10 years ago due to cases attributed to a clonal plasma cell disorder, which lies in the gray zone. So these patients are not frank myeloma patients, and in the same time, they do have a monoclonal gammopathy. This is what we used to classify as monoclonal gammopathy of undetermined significance, meaning that these patients have abnormal light chains, but they do not have a multiple myeloma. But with time, we've realized that these patients have end organ involvement, either cardiac or renal. So we started to call it, is it MIDD with NGUS? Is it a glomerulonephritis with MUGUS? But we cannot call it an undetermined significance because there is significance to this monoclonal gammopathy, and the significance is the renal affection. So the term of monoclonal gammopathy of renal significance was born. And when you look what we consider monoclonal gammopathy of renal significance, I don't know if the pointer is working. Oh, okay. So we have MGUS, monoclonal gammopathy of undetermined significance. When you have a bone marrow less than 10%, M spike less than 3 grams per DL, and clinically the patient is free. And then malignancy, when you have in the bone marrow more than 10% plasma cell infiltration, the M spike is more than 3 grams per DL, and the patient have a full-blown picture, usually with crab features of multiple myeloma. But there are patients who lies in between, and those patients who lies in between is whom we call MGRS. The updated definition of MGRS in 2019 includes that any B cell or plasma cell clonal lymphoproliferation with both of the following characteristics. We have one or more kidney lesions that are related to the produced monoclonal immunoglobulin, and the underlying B cell or plasma cell clone does not cause tumor complications or meet any current hematological criteria for specific therapy. So we have a small, dangerous clone in the patient, which we cannot classify as malignancy, but this clone is related to lesions which are present in the kidney. For example, if we take light chain amyloidosis, if the patient turns on biopsy to have light chain amyloidosis, if we have no renal involvement, this is what we call classic primary amyloidosis. If we have renal involvement meaning if we have no renal involvement, the patient is basically cardiac or he have only subcutaneous and we don't have kidney involvement. If we have renal involvement but no CRAB criteria for multiple myeloma, this is what we classify MGRS, monoclonal gammopathy of renal significance. If the patient has renal involvement and CRAB, then this is multiple myeloma and multiple myeloma associated AL. What are the lesions that we consider associated with MGRS? You can see that we basically classify them into organized deposits or inclusions and non-organized deposits. And within organized deposits, we have amyloidosis, different types of GN and the crystallopathies. And non-organized deposits, we have MIDT, proliferative, and CF glomerulopathy. I'll take you very quickly through these classifications, but this is just an idea of how they look. Most of these entities do have a specific EM picture. The diagnosis of MGRS is based on renal biopsy, and bear in mind that these patients have high morbidity in spite of that they do not have malignancy, but they have high morbidity, and like AL amyloidosis, they have high mortality as well. Let's start with the crystals, and these are the least common. Light chains can form actually crystals, and these crystals can tend to be tubulopathic, causing a disease known as light chain proximal tubulopathy. This is an uncommon disease. It's not rare, but it's uncommon. And it's characterized by slowly progressive deterioration of renal function, usually associated with Fanconi syndrome. So these patients are underdiagnosed because this is an elderly patient with hypertension, with diabetes, who presents with this slow deterioration of renal function. It's subtle. It's not always have Fanconi syndrome, and it's clinically unexpected. The course and prognosis is variable. But however, if patients do not have an overt myeloma, they do fine and they respond to treatment. This lesion tend to recur post-transplant, but they can still be reversible as long as we do not have an overt multiple myeloma. And we have reports of stable long-term function in patients with light chain proximal tubulopathy if they are diagnosed. The problem is this really an underdiagnosed entity? Because you need to stain for light chains routinely in all biopsies, and it's not easy to actually spot it. As you can see here, this tubule, all of these globules are actually the light chain crystals within the proximal tubular epithelium. You can see them here as well. It's a lesion which can be easily diagnosed, missed on light microscopy, and these are the light chain crystals on EM. This is how they look. As you can see that they are crystalline. If you stain for kappa, you see you have a kappa light chain restriction, and the tubules are beautifully stained for kappa. And again, as I mentioned, these lesions can recur in transplants. We have a more rare entity, which is what we call crystal storing histiocytosis. This is usually fatal disease, and this is where macrophage actually they engulf the crystals, the light chain crystals, and they start to localize within the capillaries, and we see them within the glomeruli, within the capillary loops. However, what also can happen is the most post-immune crescentic GN due to MGRS crystalline nephropathy. So light chains can give you a post-immune crescentic glomerulonephritis. By how they do this? They do this by that the crystals precipitate in the porocytes. So crystalline porocytopathy can exhibit a post-immune crescentic GN. This is probably due to an inflammatory response which is targeted against these crystals. And this is an example of a post-immune crescentic GN. Now let's discuss more known entities. like MIDD. Now, MIDD again is not common, but it's present and we should always have it in mind. And monoclonal immunoglobulin deposition disease can be only pure light chains or light chains and heavy chains or pure heavy chains. And these two entities are extremely rare. What we usually see is light chain. Light chain deposition disease morphology is actually identical to what we call diabetic kidney disease. So you get glomeruli with variable minimal lesion to typically nodular lesions like the diabetic nodular glomerulosclerosis. You get thickened tubular basement membranes like what you see in diabetes. And you also get the deposits in the blood vessels of the patients. As you can see here, you get the light chain deposits. This is why it's extremely important in any patients who present with a picture of diabetic kidney disease or nodular glomerulosclerosis, even if not nodular, but what looks like diabetic, to perform kappa and light chain, because in some incidences we are surprised. This is how we diagnose it. Again, this is a biopsy diagnosis, and it's a diagnosis by immuno, and you can see how the tubules are nicely stained, tubular basement membranes nicely stained for light chains. They are also detected by EM, and this is what we call black powder appearance on the tubules of the EM. Now let's discuss what is more confusing for all of us, which is GN with monoclonal deposits, the glomerulonephritis that we know of, but when it turns to be monoclonal. We have fibrillary glomerulonephritis and fibrillary GN. In 25% of patients, they tend to be monoclonal. This is an immune complex mediated glomerulonephritis, but can be monoclonal in 25% of the patients. And as you know, fibrillary used to be an EM diagnosis, but now we can also diagnose it by immunohistochemistry by DNA JB9, which is more than 90% specific. Immunotactoid, which remains as an EM diagnosis, and on the contrary to fibrillary, again an organized deposit glomerulonephritis, but in 75% of cases, this type of GN is related to a monoclonal gammopathy or an underlying B-cell neoplasm. Waldenström macroglobulinemia, you know about it, and you know that this is where we have monoclonal IgM and renal disease. A lot of hematological malignancies can cause Waldenström macroglobulinemia, mainly lymphoplasmacytic lymphoma, and also small cell lymphoma. And pathologically, it's a cryoglobulinic MPGN like what we see. And we have other types of proliferative glomerulonephritis, what we call proliferative glomerulonephritis. Now, the concept, the theory is that this monoclonal immunoglobulin, as it causes an inflammatory response, an immune complex mediated response. And this immune complex mediated response could be either a direct mechanism, so we have a glomerular deposition of these immune complexes, so we tend to have what we call a proliferative glomerulonephritis, like what we call diffuse proliferative GN, for example. And like proliferative GN with monoclonal IgG deposits. Now, this type of GN, it stains strongly. It's an immune complex mediated. So we have an IgG, we have C3, we have C1q, but we have only kappa and no lambda. So this is a monoclonal proliferative glomerulonephritis. And it gives an appearance which is identical to what we can classify as an infection-related diffuse proliferative GN or even an MPGN pattern. So we need also to have it in mind, especially if the patient's serology turned to be positive. انتوا قفلتوا عليا ولا حصل حاجه؟ احنا لسه عندي وقت. اوكي هي واضح انها بتمطر. اوكي انا مش شايفه حاجه مش عارفه اللابتوب فصل. The other entity of a proliferative glomerulonephritis is that when you have an indirect mechanism, in this scenario, you do not have direct immune complex mediated deposits within the glomeruli, but you have that the light chains initiates an immune complex response, and what gets deposited in the glomeruli is C3. Now, this is very important because now we know that C3 glomerulonephritis or any C3 dominant GN over 50 years of age is probably related to a monoclonal gammopathy. So we need to have this in mind, that if a patient is diagnosed as a C3 glomerulonephritis and they are 50 years or older, then we really need to do proper hematological screening and serum light chain screening for these patients, because they are probably might have an underlying malignancy or a monoclonal gammopathy. So these entities or these proliferative glomerulonephritis are very important to consider, because we all see them. We treat our patients, and sometimes the patients do not respond. Another entity which have been included as a result of a monoclonal gammopathy is thrombotic microangiopathy. Now, the relation of thrombotic microangiopathy to malignancies is not new. We all know that a lot of forms of malignancy can actually cause thrombotic microangiopathy. But when in a study by Mayo Clinic, when they revised retrospectively a good percentage of their patients who had thrombotic microangiopathy, then they have found out that they did have around 50% of them, they had a form of monoclonal gammopathy. Now, the one which follows is membranous glomerulonephritis, our membranous glomerulonephritis. Now, there is a membranous glomerulonephritis with monoclonal deposits. So, how do we detect this type of membranous glomerulonephritis? These patients usually they are usually above 60, and they tend to have a bit of specific features within the biopsy. If the membranous GN is associated with a lot of leukocytes within the capillary lumina, we need to suspect that this is malignancy or could be monoclonal. If we have crescents with this membranous GN, then this also gives you an idea that this is not a straightforward membranous GN. But most important, that these patients are APLA2R negative. They are phospholipase negative, and hence the importance of phospholipase staining as well as thrombospondine. And we do not want to mix, because we know that thrombospondine is highly associated with the presence of malignancy. And when we screen for malignancy by thrombospondine, then our patients will turn to be, when they are negative, we consider it a primary MGM. However, when we have double negative, then we need to stain for light chains as well, because this could be also a membranous GN with monoclonal deposits. In any patient above 50 years old, we need to really consider that first, this should be a routine workup. Yes, it should be a routine workup in any patient above 50 years old, and it should be routine that we do have a kappa and lambda staining within the biopsy. Okay, as I mentioned.
Go ahead.
نعم. لا تحت ال 50 then it is going to be upon suspicion. يعني I would consider it in our patients that we should start from 40 years old, from what we see. We should start from 40 years old. Okay, now, so as I said, membranous glomerulopathy with light chain restricted deposits. The majority of cases, we doubt them with absence of phospholipase positivity, positive staining for a single IgG class, or presence of focal proliferation and crescents. Finally, the major MGRS that we see, and the commonest, is AL amyloidosis. AL amyloid is the life-threatening form of systemic amyloidosis, and a reported median age at diagnosis in the Western literature is 63 years old. But I want to tell you that the median age in our patient cohort is 30 years old and 35 years old. I also want to remind you that AL is not only related to multiple myeloma, and to remind you that you can have only AL without the involvement of malignancy. However, AL is a highly fatal disease. It's a very toxic form of amyloidosis, and it affects multiple organs. This is AL, and this is how we do it. This type of amyloidosis leads to varied presentation, so it's very much delayed in its diagnosis. It can be very subtle in early cases. It does not always come alone. Patients could have another disease. It could be superimposed on an underlying FSGS or diabetes, so you could have other pathologies in the biopsy. And in our series, AL amyloid comprised, we have phenotyped more than 1,000 biopsies with amyloidosis. And this is the results of our phenotyping in relation of AL amyloid, basically 1,032 biopsies in the last 10 years from our database. And you can see that AL amyloid comprise around 20%. So this is the second commonest type after AE, almost equal to the new type of amyloidosis, which is LUCT. The majority of our patients were male, 60%. 20% of our patients were less than 50 years old, and 10% were less than 40 years old. So it's not 63, It's not a disease of elderly, and it's not a rare disease. So we do see it, so keep it in mind. And as I say, this is a disease which could be very subtle in the end. The average serum creatinine for these patients was 4 milligram percent, and 60% of cases present with nephrotic proteinuria. Multiple myeloma time of the biopsy was only present in 20% of the cases. 80% were Lambda type, which is what we expect in AL amyloid. However, the kappa type correlated more with the presence of other pathologies. So these patients did not only have amyloidosis, they also had cast nephropathy and proximal tubulopathy. So when you have a kidney biopsy and we do immunoglobulin or light chain restriction, and we have an immunoglobulin light chain restriction, then we see whether we have serum and urine monoclonal studies, protein electrophoresis, immunofixation, and so on. So we proceed to bone marrow aspirate and biopsy, and we need to proceed to lymph node biopsy. This is if it is positive for immunoglobulins. However, if we only have C3 dominant deposits, then we consider this a monoclonal, and we have a monoclonal gammopathy. We do not need further hematological workup, because this is also related, monoclonal gammopathy is related to C3. So finally, my take-home message is there are several mechanisms by which monoclonal immunoglobulins cause renal injury. The pattern depends on the location of deposits in the kidney. These are not always isolated entities, so remember this. They are commonly superimposed on systemic disease. They change their phenotype, so patients can start with light chain cast nephropathy, then develop MIDD, then develop amyloidosis. And this could be the reason why your patients do not respond, why they are not reversed, and why they are not weaned off dialysis. And it is not limited to old age. This varied, inconsistent clinical, hematological, and pathological findings needs a high degree of suspicion. So be suspicious, because suspicion, it does not only save your kidneys. Early diagnosis does not save the kidneys of their patients, but in this scenario, it also saves their lives. Thank you very much.